Local nerve blocks and trigger point injections have been gaining popularity as adjuncts to our treatment of headaches. And I have to preface this video with a disclaimer that we don't really know how they work. How do they make the headaches better? We theorize that they might decrease the afferent tone of nerve fibers or break the pain cycle, but the reality is it's unknown. But the great thing is that they have low risk and potential for high benefit, and they're a great adjunct to our traditional oral or IV medications. So let's talk about 3 nerve blocks. Well, actually 2 nerve blocks and 1 trigger point injection. We're going to go over the occipital nerve block, the paracervical trigger point, and the sphenopalatine nerve block. I want to start off with the anatomy of the greater occipital nerve and also the lesser occipital nerve. And this is that nerve that you're going to be going after when you do an injection with local anesthesia on the posterior aspect of the head. So the greater occipital nerve really kind of comes up and cruises up and innervates the top of the scalp from the external occipital protuberance to the vertex. The lesser occipital nerve comes out lower and really innervates the lower aspect of the scalp and the posterior neck. And to find these nerves, you have to know where you're going in terms of your anatomical landmarks. And so the best way to do this is to take a line from the center of the mastoid right back here to the external occipital protuberance. So now you have a nice line, and you're going to trisect it into the proximal 1/3 and the distal 2/3 right here. And so the greater occipital nerve is located at that cut, that 2/3 cut. So here's my line, and if I cut this 1/3, 2/3, it's going to be in this region here. One of the landmarks that I find is helpful is using the inferior nuchal line, which is kind of that ridge in the back of your occiput that you can feel. Also, you can palpate the occipital artery, and the greater occipital nerve is just medial to this occipital artery. So the point is going to be right in this spot here. And that's the main nerve we're going after for our occipital nerve block. The lesser occipital nerve is going to be at that 1/3 cutoff. So cut off here, and you go right here, mastoid process, and it's going to be in this region. The beauty of this nerve block is when we're doing it, we're going to be fanning our anesthesia anyway, so you're going to be trying to get that nerve as it cruises up towards the scalp. All right, now on to the paracervical trigger point injection. So this is not a nerve block because you're not going after a specific nerve. It really is a trigger point injection where you're trying to get into the plexus of nerves that are in the neck. For this, the anatomy is really nice and easy. You're going to go down the neck and palpate the posterior aspect of the posterior spinous process of C7. It's that big lumpy one right above there, between 6 and 7. Then the needle injection, the trigger point, is going to be 2 centimeters lateral to that, straight into the musculature of the neck. Not upward, not downward, not laterally, and not towards the spinal cord, but really straight in. And we're going to do that on the bilateral aspects of C6, C7. And finally, let's go over the anatomy of the sphenopalatine nerve block. And this is really going to be inside of the nair. The Sphenopalatine Ganglion is kind of a complex region of cell bodies and nerve fibers that control some of the sensation to the maxillary branch of the trigeminal nerve, etc. And when we're going after this is not going to be an injection. This is an application of a topical anesthetic. And so we're not going to be able to see exactly where we're going to be touching this, but we'll be able to use our landmarks to find the Sphenopalatine Ganglion. The Sphenopalatine Ganglion is located right here behind the posterior aspect of the superior turbinate. And so when we apply this anesthesia, we're going to be going into the nair and placing that Q-tip right up into this aspect here so it sits up on the nasal mucosa of the internal nair in this area right here. And you're going to be hitting that Sphenopalatine Ganglion. Okay, so now that we know where we're going to be doing our nerve blocks and our trigger point injections, let's move on to how to actually do these procedures. All right, so now that we have our patient and we're ready to do our nerve blocks and trigger point injections, let's quickly review our equipment tray. And thankfully, this is a very simple equipment tray. There's not a whole lot that you need. You'll need an anesthetic. In this case, I have bupivacaine. Alternatively, you can use lidocaine, 0.25 for the bupivacaine or 0.5 if you have it, or lidocaine. I like to use 2%, but if you only have 1%, that's okay as well. Some people will even do a 50-50 mix. I'll do 50% lidocaine, 50% bupivacaine, so they get the earlier onset of the lidocaine with the longer lasting effects of the bupivacaine. In general, I just grab what I have, and that's handy. I'll have an alcohol swab so I can do a little local prep where I put my needle. I'll have my syringe with my anesthetic. This is a 27 gauge long needle, so it's about 1¼ inches. I like that length because it helps me with my paracervical and occipital nerve blocks. I will also have my 4% viscous lidocaine, a cotton tip applicator for our Sphenopalatine block with that viscous lidocaine. And here I've added an atomizer, and I'll show you what I'm going to use this for. I use this to kind of do a little anesthesia in the nair before I do my Sphenopalatine block. We're going to start off with the occipital nerve block, and we're going to go over the greater occipital nerve bilaterally as well as the lesser occipital nerve. And you know, the teaching really has been focused on the greater occipital nerve. Some people will add on that lesser one because they think it has a better effect. The data is not super strong for both of them, but again, the risk versus benefit is so much outweighs the risk that by all means, just add a little bit more of anesthetic. So let's go back to reviewing our anatomy, the stuff that I showed you on the model. I'm going to go over it again on our live patient. So you're going to find your occipital protuberance. That's that bump at the top right here. You can feel sometimes that occipital ridge that cruises down from it, and then your mastoid process right here. And so when you make that line from the occipital protuberance to the mastoid, that's the line that we're going to be cutting into thirds. The proximal 1/3 and then the distal 2/3. And the proximal 1/3 is where your lesser occipital nerve is going to come out, and that's going to innervate the scalp, the lower scalp and the posterior neck. And then the greater occipital nerve is going to do from the scalp up to the vortex in this area. I like to use this block for tension headaches. I'll sometimes also use it for my migraine headaches. When we're talking about what's the data, what's the most robust for, this one doesn't have a specific headache where we have really great data, but I've had good effect for both of those types of headaches. So what I'll do is I'll just prep my area. I'll keep my finger on my mastoid process and the occipital protuberance, find where my nerve is coming out. I'll clean that area with my alcohol. Now, remember, the patient has a lot of hair here, so no biggie. Just spread it out and clean it up with your alcohol swab where you're going to inject. I'm also not wearing gloves for this procedure. Technically, I normally would be wearing gloves, but for learning purposes, we're going to go sans glove. Once you've found your spot, you want to grab your needle. I have my anesthetic. This is the greater occipital nerve. And when I go in, you just want to go under and make a little bit of a skin wheel, pull back. Make sure you're not in any vasculature, little skin wheel. And then the bone is really superficial. So once I get in, I tuck it in, I hit the bone, and then I just inject 1 cc of local anesthetic. The next thing I'll do is I'll pull out and I'll fan it to the right. Do the same thing, pull back, inject a little bit more, and then fan it to the left. And now what you've done is you've really created an area where this nerve cruises up in a single line, and then by fanning out, you've increased your chances of hitting that nerve before it goes up into the scalp. Alternatively, remember we talked about palpating the occipital artery. Remembering that the nerve is just medial to that, you can do that as well. You feel that artery in the same general area that you want. If you want to be a little more pinpoint and a little more precise, you just go just medial to that, making sure that you're not injecting into the artery, obviously. That brings me to another point is when you're using your anesthetic, this is all going to be without epi. There's no need to have epinephrine inside with your lidocaine or your bupivacaine. People will also sometimes add a steroid to this for longer lasting anti-inflammation for headaches. We don't have any good data on that, and so I don't routinely use that. I don't usually have access to steroids easily in the clinical area that I work. So now that you have your greater occipital nerve, we'll go and do the lesser occipital nerve. Same thing, if you need to find your landmarks again, mastoid process right in this area here. I'll clean that area up. And we'll just basically repeat, right? Little sub-Q wheel, pull back, go to bone, pull back a bit, 1 cc, fan out, fan out. I would repeat the exact same thing on the other side. So now you have the bilateral aspects, and I'll leave the patient here, come back in 10 minutes, ask them if their headache's better. If it is, great, I'm sending them home. If it's not, well, then I can move on to my traditional oral or IV medications. Oftentimes, the patients also say they feel numbness in this area. That's absolutely normal because you're doing a nerve block for the sensory. So they should sometimes feel like, oh, the top of my head is asleep. And that doesn't last very long. And in reality, they're just happy to not have any more pain. Okay, so now let's talk about the paracervical. Remembering this is a trigger point injection, not a nerve block. This is the one that's going to be lateral to the C7, C6 posterior spinous processes. And this one, traditionally has been taught for migraines, but I will also sometimes use them for tension headaches. In reality, the data for this trigger point is not as great as it is for the occipital nerve block. But again, clinically, I have had great success, and you're just putting a little bit of anesthesia inside basically a muscle bed, and so the risk is extremely low. For this, I'll do the exact same thing. You're going to find your landmarks. I'll use my thumb, find my C7 posterior spinous process, move up, feel C6. So now I know the area I'm going to be working in. This is my midline. I'll prep that area with my alcohol. And remember when we talked about this needle is going to go 2 centimeters lateral to the midline. So 2 centimeters right about in this area here. I'll do my little subcutaneous wheel right there. And then you want to take your needle and you're going straight into the musculature of the neck. You're not going towards the spinous process. You're not going laterally. You're not going up. You're not going down. You just want to make that nice 90-degree angle on that plane and imagine you're going straight in. People sometimes get worried, oh, what if I go into the spinal cord? You can't. The needle's too short and the spinal cord is behind bone in the midline. All you have here is really your trapezius and more musculature. So I'll take that needle and just about almost hub it, about 1 inch to 1 1/4 inches in, pull back to make sure I'm not in vasculature, and I'll put 2 to 3 cc's of anesthesia in that spot, pull out, rub it in, and then repeat the exact same thing on the other side. And now you have bilateral paracervical trigger point injections. Really nice for the tension headaches, real nice for the migraine headaches. I'll come back in about 10-15 minutes, ask the patient if they're feeling better. If they are, awesome. I'm going to send this patient home. If they're not, well, then again, we're going to move on to our alternatives. The patient's not going to feel any numbness. Sometimes they'll say, oh, I might have a little bit of tingling here or there, but this isn't hitting a nerve exactly where you now have numbness of any of the cutaneous areas of your body. Paracervical trigger point and the occipital nerve block. There's nothing wrong with combining them. Oftentimes, if one of them didn't work, if my occipital nerve block didn't work, I will add this trigger point and reassess the patient, realizing that as long as you're underneath the toxic doses for your lidocaine or your bupivacaine, which you are going to be, we're not using a lot here, you're absolutely fine to combine them together. All right, and finally, the pièce de résistance, the Sphenopalatine Block. For this, I'll have the patient facing me. This is a block that is used for migraines. I've mostly reserved it for migraines, but as you're going to see, it's putting something in someone's nose, but it's a lot easier than it looks. So let's walk you through how to do that. Remember, in the anatomy, the Sphenopalatine Ganglion is inside the nair, right posterior to that superior turbinate. And so similar to when we're doing like an epistaxis packing, you're going to want to think about that anatomy and how you're introducing your topical anesthetic. I've added something to this that isn't really talked about in literature in terms of doing the actual block, but I like to do a little atomized lidocaine, 2% with or without epi. This one's without epi. Just a little half cc atomized into the nair prior to actually doing the Q-tip with the topical anesthetic. I find that it makes it a little more comfortable for the patient. And to be honest with you, I'm putting lidocaine in the same area. It's just a different form, right? It's the liquid atomized form as opposed to the viscous form. So to do that, we have our atomizer, and I'll just say, go ahead and sniff back, and I'll atomize, let it sit. I'll let that sit for about 5 minutes, and then come back and move on to the next step. The next step is going to be using our 4% viscous lidocaine and the cotton tip applicator. Remember, guys, in this video, I am not wearing PPE. I don't have a mask. I don't have goggles. I don't have gloves. In a normal clinical setting, I would have all of that. The patient can sneeze on you, etc., and you want to protect yourself as well as just the patient. So what I'll do is I'll take that 4% viscous lidocaine. I've applied it to the tip of my cotton tip applicator, and now I'm going to introduce this into the nair. In the same way I would for packing, you want to go horizontal on the medial aspect, avoiding the turbinates that are on the lateral aspect, and you don't have to rush this. You're just going smooth, slowly, patient comfort. Eventually, a lot of patients, if this works well for them, I will teach them how to do it, and then they can go home with a cotton tip applicator and some lidocaine, and they can take care of their migraines themselves if they're comfortable placing this in their nose. And so when you're doing that movement, just stay still right here. The patient is seated here. You could have them lying down, and I just kind of twist and go horizontal up. You're going to notice it's going to go upwards towards the head a little bit. That's the normal anatomy of the nose as it goes along those turbinates until you hit resistance. And once you hit that resistance, done. You leave that Q-tip in. I will do bilateral nairs in general for real bad migraines because I have better anesthesia, but I'll just leave them both there. We're not going to torture this patient. And then 10, 15 minutes later, I come back. Hey, how's your headache? If it's better, awesome. We remove that, send them home with instructions, return precautions, but I had some good success. And remember, if this doesn't work, that's okay. You've tried a non-oral or IV medication treatment. It's taken you maybe 10, 20 minutes of your time, and you can always revert to the oral meds or the IV medications that you typically use for your migraines. But I like this because you can oftentimes treat that migraine really, really quick, get the patient feeling better, and avoid that entire step. So the Sphenopalatine, remember, migraines, the occipital nerve, migraines and tension, and the paracervical trigger point, also used for tension headaches and migraine headaches.
This is Hippo Education.